you're either here because you might have some hip pain or because you're, trying to figure out what it's going to be for other people that you want to tell back and tell them, oh, here's the information I found for you. And so first we're going to talk about what the hip joint and why is it so special. And then we're going to go through the most common injuries. And now you get to be extra special. Although some of us have had some hip injuries that they can share as well, to be able to figure it out a little bit. And then we're going to connect it with how does it relate to running mechanics. Okay. All right. So we're going to start. Here's our little worksheet. So what's so special about this hip joint? So for some of this, it's a connection between, so the joint is where two bones meet. And for the hip is where the femur or the thigh bone connects to the pelvis. So the femur is connected. So we're here, space. So you have the femur here, this little knob, space.
You're so good at that drawing.
Femur. It's connected to the pelvis. So here's the socket here, and I haven't drawn this in a while.
No, you're good at this.
Something like this, because I wanted to do the other one. I'm going to do the side joint here, and here it comes like around. And then here's the other side, but then here's the, and then we have the spine right here. So there's one side. Okay, so this is connection between the femur and the pelvis. And then it's a ball and socket joint. So there's a ball and your socket, which means it gives it tons of freedom of movement. That's why you can move it in all kinds of places, just like your shoulder. So the hip joint absorbs extreme forces. However, it has supporting structures. I'll probably come over here. And some of those supporting structures, then they're going to be soft tissue and they're going to be muscles and ligaments. So if we head over here, here's the hip is going to be right here, right? This is from behind. Tons of little hip rotating muscles, and then lots of ligaments. In this case, the interesting thing about the ligaments, I'll show you in a second, is that it doesn't just connect. So I'll come back for that. So that ligaments actually have this sort of, the hip capsule sort of attaches here. And it's kind of like a sleeve, except it has sort of a winding way of where the fibers are. So the muscle fibers don't just attach like that. They're not the muscle. The ligament fibers don't just attach. They have this sort of windy direction, which makes it one of the most stable and strongest joint in the body. So with the different direction and sort of like that spiral direction of those muscle, of those ligament fibers, that's how we end up with some of those injuries. So going back to, so hip capsule, yep. So the muscles, I wanted to review a little bit of those muscles that you can't quite see in there. You have different muscles, so this is the front. And you have muscles that attach around here, and they all cross over the joint from the back. Some come from the front and attach into the spine. So we'll come back to this one actually. Oh, even better. So I'm going to make this one. Here's your femur, right? Here's the little ball and socket, right? We have the hip flexors that attach from the front. This is with all the organs taken out. I'm sorry. Can you turn off the radio, please?
Yes.
Thank you. Still have the disco in the background, right? So the hip flexors attach to the front of the femur, and they go in through the abdominal cavity and attach to your lower back. From the back, you have all the glutes and all the hip rotating muscles that attach from the back of this little nub over there. So ligaments, hip capsule, muscles. That's why it's so strong and stable. So with hip pain, it can be from an internal or external source. Internal is inside the hip joint, so inside that ligament structure. External could be muscles, other little tendons attached to it, and outside of those, of that capsule. So, the other thing that we'll leave it at that. Okay. So that's our hip joint. At the same time, right around the hip joint, you have different nerves that travel, that come out of the back, and they travel right behind the hip, and they cross over the hip joint to go into your leg. So, that's sort of the basic of it. So, I'll tell you a little bit about me. You guys already know most of it. I've been a physical therapist for 11 years, and back in college I used to be a rower, and I had my share of back and knee, and I think shoulder injuries. I had so many. And I wish I'd known a good physical therapist, or even my coach, not so great. But I actually had an excellent sports psychologist who really helped me go through my own injuries. So I was always interested in sports. I did exercise physiology as an undergrad, and then I went out. I was a strength and conditioning coach for about a year and a half or so, training speed, agility, power for athletes. And then I got bored, and I thought, I gotta work with more difficult people, and so that's when I went back to PT school. But I still always loved orthopedics and sports. So got out of PT school, worked for a few years, and really noticed that I went to school, I learned all these techniques, and all the people, I had to work on 3 and 4 different people at the same time. And so all these skills that I learned, I couldn't really do anything with them because I was like, okay, stand up taller, work on something else. Oh, the heat is done. Can you get the heat? And so my attention was all over the place. And so, which is why almost 3 years in January, I started Fluid Physio. I sort of, I wasn't participated, or I worked for a couple of different practices, and the small privately owned practices were sort of dying out because of insurance, and that's a whole other story I won't get into. But so I found myself, I was like, you know what? If I could just have one person and really focus on them, there would be so many things that we could do and pay attention to that they could do manual therapy, go do something, oh, that doesn't look good. Okay, do something else, and then do a movement. But what is it specific? Are they runners? Are they martial artists? Are they just grandmoms that went to play with their kids on the ground? Depending. So I started Fluid Physio, and so a little bit about that. So the type of practice that I had before, I'll do this. I saw a lot of people that, it's okay. Physical therapy, our bodies like to heal. So it's like, well, it's okay. I mean, it still has little things, like maybe it's not full range, but I can go back to live my life and do my things, something like that. And then I had some people who are like, this isn't working out, or they'll drop off, stop coming in. And then I had a number of people that, oh yeah, this worked, I can go back. But I was like, okay, this is enough. I'm seeing too many people at a time. I want better, because I know I could do so much more. I did an extra residency in orthopedics, and I had these manual therapy skills that I just couldn't use. Fluid Physio, we see something a little bit different. Because we focus one-on-one, lots more people actually reach their goals, and everybody has different goals. Your kind of running is not necessarily the same thing that Natalie's kind of running. And so, because you're looking to accomplish different things. Some of us have to go home and deal with kids. It's a different kind of running, since we're talking about running. So a really good number of people that we really were able to connect and help them reach their goals. There are a number of people that, you know what, physical therapy is not for you. Maybe there are way too many global issues that it's like systemic. So where there's, you're not feeling well, whether it's blood pressure related or whether it's just symptoms that don't quite match to a musculoskeletal or nervy kind of related. There's just so many things, which is something that we refer people out to. And so we are connected with different physicians, and we can say, hey, like Dr. Renger, I heard you say Dr. Renger. I'll call them up and I'll say, hey, can you get someone in? And then that's the type of people that, there's something else out there, and physical therapy is not it. So, much happier. And I met you right around the beginning.
I think you did.
Yeah.
I actually trained her neighbor.
That's right, that's how I met
I
with
know.
Vicky.
I know.
So, my neighbor, and then that's how I met Natalie. I was like, wow, this is the kind of people that I want to work for. I want to work with.
Yeah.
So, do you know, I mean, you can already introduce you and
Oh,
a
Her
little bit.
daughter worked with her.
Yeah.
Yeah, so, but no, I've been doing, I've been an athlete for like all my life, and then I started my company, it's gonna be 6 years in November. And I never thought I would be doing what I'm currently doing, and even transitioning into the more like gait analysis type of thing. I started out coaching adult marathon runners, and now it's like I train anyone from 8 years old to like 70, and then everybody's different goals, you know, and I tacked on massage therapy. So now I have that as another tool to just kind of help somebody, you know, recover better from, and then, you know, obviously if I can't do something, I send out.
Yeah. So, a little bit different, and
Yeah.
so like the fact that Natalie only coaches running.
Yes.
That is, you know, yes, I was a strength and conditioning coach, and yes, we did some running mechanics, but Natalie's the running coach, and so we work together to where if there's something that, things don't look right, people are having pain, that you shouldn't be running with pain, because one thing leads to another. And so then this is kind of, you know, I've had athletes that come to me injured, and I'm like, yeah, your running just needs a little help. You're almost there, but you need to work on your running mechanics. I know just the person for you. So Natalie would get like, here's what I think they need. We've been working on this.
Yeah.
Have fun. And you've gotten some interesting.
Oh yeah.
Interesting.
I still want my one barefoot runner to go in shoes, but
He won't do it.
he won't do it.
Barefoot,
Yep. Yeah. So anyway, so that's a little bit about us. So does anybody want to share a little bit about what their hip issues might be? Because I want to make sure that I address your particular questions. Would you like to run?
Oh, you want me?
Yeah.
If you'd like to, yes.
We're all
I
confused.
just had a labral tear in March, and
Of this year?
I didn't know what it was initially.
Mhm.
It was, I thought it was, but the original orthopedic, I had groin pain,
Mm-hmm.
and so the original guy diagnosed it as just a muscle.
Strain.
Yeah. And so I did PT and it helped me. And I've done PT before for other things.
Mm-hmm.
And then it's not like I'm a big runner or anything, but I do, it's a part of my workout. I go to Orange Theory. So it is,
Fun. It's really
yeah,
fun.
it's like half an hour of running.
Yeah.
So I didn't do it for 2 months. And then I restarted doing it in June. So no, in June I had the MRI. With Dr. Wenger, and that's when they saw the labral. But by then I didn't have any symptoms anymore, and I was back to working out, so he said just keep doing that. So I get hip pain occasionally, it's not like all the time.
Uh-huh.
I do the band exercises and
Like the clamshell and stuff.
And what makes your hip hurt?
it's usually not while running, it's after. I've been very careful. He told me not to do inclines, so I don't do those unless I'm walking on them. But I don't run on them anymore. I run at 0. And so it doesn't hurt. If I do it several days in a row,
Then you
then
feel
it
it.
does.
Okay.
So if I work out 4 or 5 days in a row, then it hurts me.
Okay. All right.
Then
So you sort of managed it to a certain sense.
yeah, I don't like to take Motrin and stuff. So I don't usually.
Okay.
So but I do the hip strengthening exercise, whatever they taught me every day, and stretching.
So
My job also is kind of sitting all the time, so that doesn't help. If I sit for a long period of time, it actually hurts me.
Got it. So bringing up the labrum, and I'll sort of point it out here, but I missed it. So we talked about the ball and socket joint. The labrum basically is just a little extra piece of cartilage that extends that articulating surface little bit, enough to create a little bit more stable position. So it's just kind of a little piece that sticks out like that. So any other hip issues that you might want to share?
You're talking about me?
Anyone? Well,
I just have mild bursitis on both hips and sciatica.
okay. All right. All right. Hip pain is not one that I've dealt with. All the other joints around it I've dealt with, but
It's good for me too,
okay. Good.
so far.
All right. Let's keep that.
So far.
Okay, so let's go through the most common causes of hip pain, because there were a little bit. So we talked about external and internal. So one of them, Nali mentioned bursitis. So we have, I'm going to go back to this diagram with a dark color. Bursitis is just a little pocket of fluid that cushion the tendons or the muscles from something else. So in the case of, we have the hip flexors here, there's actually a little bursa right underneath here. You see this little ligament? It cushions that muscle from the ligament. There's also little bursas right around here. You see there's all these little tendons that come in?
Yeah.
There's little bursas underneath there. So those are there's little bursas underneath the pelvis at the bottom. So you can have them in different places. And so this is going to be external hip pain. And so for different reasons, you can have inflammation of the bursa. One of them could be when you're overusing your hip flexors as a result of not a strong enough deep core. You can overuse them, run like this, and irritate the bursa. The same thing for the glute bursa, the trochanteric bursa. Those you can irritate for the similar reasons, or overtraining. So a few different things that irritates them. So usually it's on the outside or the front of the hip that it's a bursitis, but sometimes that can actually radiate down the thigh a little bit. Rest, ice, you can do Advil, but ultimately, and yes, it'll go away and calm down a little bit, but if you don't treat the actual cause, like the deep stabilizer weakness, it's just gonna come back. If you don't treat, if your hip flexors are short, not flexible enough, that's gonna keep irritating it, it's gonna come back. So people, usually this is one that's called the snapping hip syndrome. That's exactly what that is the inflammation of the bursa. All right, so the second one is gonna be labral tears, and that's also pretty common. So we drew that little pink labrum there. This is actually going to be an internal impingement because it happens on the inside of the capsule. So the capsule actually goes over it, right here, and that's the inside of it. So that's internal impingement. And some of this is a result of bony abnormalities. So some people, I'm going to draw them here. Some people have a really big femur that then creates an impingement of the labrum here simply because the femoral head is so large. Okay. Some people, that's really small, but anyways, some people are opposite. They have really big acetabulum, or the pelvis side of the joint it's much bigger, and it creates impingement of the capsule. Some people have both, have really large acetabulum and really large femoral heads, and that can also happen. And so usually, because they create these structural abnormalities end up injuring the labrum, that is actually something that it can happen for, it can be seen at a young age, it can be seen later on, but oftentimes those are things that may or may not require surgery. So if it's one of these bony abnormalities, And if it's, for example, a teenager that has a lot of hip pain, I had a rower, every time he went to the catch, he was in 10th grade when he was diagnosed with impingement as a result of bony abnormalities. So every time he went to the catch rowing, he would have hip pain. He ended up having surgery in both hips to correct these bony abnormalities. He's back to rowing, and he actually got invited to train with the national team.
Oh, wow.
He should be a senior right now. So that's pretty cool. So you can correct those, especially with kids. As an older person, we could have had these things all our life, but until we did something to, normal wear and tear, creates a little bit of that labral pinching. You didn't have pain before, now you do. Well, there's different things that can keep you from this coming back. So this actually presents as deep hip pain and also groin pain. So you might, some of that pain will be felt in the groin.
Yeah, that's what
And so it's very easy to say, oh, it's groin pain, you just have some bursitis. But there's very specific tests where you just put some weight and you grind that joint and it doesn't feel good. Because then we can elicit that pain. And that's where, just as you said, weight-bearing pain, so when you run for too long, right? Now there's different things that can can help you not have that. If you have been diagnosed with a labral tear, there's different things that you can do that it sounds like you're doing, limiting your running, making sure that you stretch, and making sure that your deep core and that your muscles around it are strong.
Yeah, I started doing Pilates
Mm-hmm.
to help me.
Good, good. Because oftentimes when your core is not strong, when the deep core stabilizing muscles aren't strong, you're going to compensate with your hip flexors. And then that's just going to create more compression through the joint, because all those hip muscles, as opposed to your large stabilizing muscles, are just compressing the joint because they're being used for something they're not.
So icing doesn't help with that, because it's inside. So
Yep, pretty much. You might numb it out and
Like pain modulator.
yeah, but other than like to actually make it heal, not really.
but he told me it doesn't heal.
Right.
That's when he goes. He
So
said it's there.
Yeah.
So here's what can happen with a labral tear. Part of that little labrum, you know how you get little hangnails in your some of it like kind of sticks out and they can be
Yeah.
caught up, right? When it gets irritated, maybe because you run for you got really excited and you ran around too many days in a row. That creates a little bit of an acute inflammation, right? That acute inflammation, when you don't inflame it, it's kind of calm and it's as if you didn't have anything, right?
Yeah.
So that acute inflammation, then the pain gets brought on by something that you did, and then eventually it can calm down to where, that you don't really feel it anymore. But that little hangnail is still going to be there. Yeah.
Yeah.
Makes sense. So it's not that, so it's not going to go away. Now, the other part is they've just recently, within the last 5 years or so, remember like last 5 years or so, that they started doing labral repairs in more of an adult population, where they, just like the meniscus, they would go in and clean up the meniscus. Oh, we're going to go in and clean up the labrum. I have yet to have, and maybe you can share if you had in your practice, but I have yet to have a patient that had a successful repair that all their pain went away.
I had one, but she also had, she was older, she was not athletic, just walking things. I don't want to say not athletic, but she also, it was post-hip replacement that this happened, and she also had a glute knee tear, I believe.
Yeah.
Or glute knee tear, so
So-
she, a little bit different.
Yeah.
So there's no point in doing the surgery.
I would wait for other people to be experimented on and for them to find a better technique. Because it hasn't, ultimately the question is, how badly does it impact the quality of your life? Oh my God, I have to run. But if you have the surgery, you're probably not going to be able to run anyways. again, it's what is important to you. And ultimately, so what happens with adults that had these impingements that later on, that maybe because they had another one that had the surgery, was a police officer. He was about to retire when I started working with him because of hip pain. And we were able to, with manual therapy, calm it down, but he sat all day because now he was the, how do you call it? The chief. And so he did a lot of sitting in the office, and he's like, oh, this is awful, you know, I can't work out the same way. He couldn't do many things because it would pinch. He had the surgery, and he still dealt with a lot of pain. Afterwards, there was a lot of bursitis happening and a lot of all that stuff. But ultimately, he still had to deal with some pain and just sort of learn to manage it. It wasn't as bad as it was because he had it on both sides. But ultimately, that's going to just develop arthritis, and he's going to end up with a hip replacement. I had a similar case, but this woman, she is in her mid-50s, so similar age as the other gentleman, except she was told just go right into the hip replacement. And she feels great. She had the hip replacement, she's walking better, she can wear her heels, she can exercise within, you know, she's not running, but she just went right to the replacement, which is ultimately what the other guy's going to end up doing. And there you go.
I would prefer not to have one.
Right, so
Touche.
again, right. So again,
Because that's.
what is the quality of your life and what does it impact? So, surgical repair. So manage it. And so moving on, stress fractures is another common one in runners. And it's usually overused. The most common stress fractures happen in the pelvis. So that's sort of like a deep pain. And although people are like, well, it's only a stress fracture, it's still a fracture. And you have to heal it. So you have to let the bone heal. So
That takes a long time.
bone heals about 6 to 8 weeks for bone regeneration to happen. Now running is a lot of impact, and actually some impact, and so for older population, you tell them, yes, do a little impact, because the impact will promote, bone regeneration. So at the same time, but not too much to get yourself going. So the next one and the last one is going to be piriformis syndrome. So if we come back through here, the piriformis is the biggest nerve in the body, and it comes out right around here. It's a really thick nerve, and it comes all the way, it splits, and it goes into the bottom of the leg. Sometimes, again, this is another external hip pain, and it's actually pain in the buttock generated down into the thigh. So we talked about the piriformis muscle, the sciatic nerve, and so this can technically be a big pain in the ass because it's just deep pain. And so different things that can affect the piriformis and the sciatica is more, sometimes the piriformis is short, sometimes the glutes are weak and the inner hip muscles try to compensate, and that's what happens. So that's about that. So one of the ways that we sort of help manage some of these is going to be through manual therapy, and it sounds like you had physical therapy. Can you tell us about your physical therapy experience?
Like what did I do?
Yeah, like what did you do and what got you to what you're doing? You're saying that if you do your stretches, right?
So I did it, how long did I go for? Like 2 months, maybe 2.5. I went twice a week because that's
For 2 months.
on my schedule. Twice a week was the only time I could do it. And basically at that time we didn't know it was a labral tear, so she was kind of treating it like a muscle.
Yeah, because that's what they told you at first,
Yeah.
right?
So, and I hadn't had the MRI yet, so we just did a lot of hip strengthening with the bands and not much manual therapy.
Okay. Did you end up having an experience with manual therapy?
No.
Okay.
Monica did, my daughter did. She went
Yeah.
to, what's his name, forgot his name.
Whoa.
He,
Mike?
he's somebody, Mike. I think the one on Herrington Road,
I think I remember a mic.
maybe Mike, yeah.
Yeah.
That's who Vanguard sent her to take manual.
Uh-huh.
Yeah, but I didn't, she did a little manual manipulation, my physical therapist, but
Mhm.
not much.
Not very much.
I had PT last year also because I had
Uh-huh.
a sacroiliac flare,
Oh, okay.
so.
So, yeah, it sounds like
Interesting
there's
combo.
some
But that didn't come
weakness.
back, that, I had that last summer, and that
Mhm.
was fine.
Yeah, and that sounds like perhaps there's a bit of weakness and imbalance in the deep
Yeah.
stabilizing core. So manual therapy, so for example, for the labral tear, for manual therapy, we would mobilize the joint, actually create more space within the joint with different techniques. Have you, do you wanna try it out? Should I take it? I'll just do a little bit.
Okay.
So let me have you, any major surgeries or anything like that?
No, I'm
Alright, let's keep it that way.
Yeah, thank you.
No, keep it that way. Alright, the other thing that creates a big impact in hip health is your lower back.
Okay.
So lower back, so the SI joint is gonna be right here, and the lower back, your hip flexor is attached to your lower back. So if you have poor mobility through your spine, then that can impact your hip pain. So for you, it's gonna be really important to keep your back mobile, keep your hips strong and flexible.
And my job is, I'm a psychiatrist, I sit for
Okay.
long periods of
Uh-huh.
time, so-
Yes.
but that doesn't help.
My mom's a psychiatric nurse practitioner.
Oh, she is?
Yes.
Where does she work?
Outpatient in the Northeast Philly.
Oh, okay.
So,
Nice.
she loves it. Can you go into a squat? What are some of the things you were saying that sitting? Okay. All right. Good. So let me have you sit right over here, please.
Sitting, if I
Yes.
sit for a long time,
Uh-huh.
so I try to get up and walk around, but sometimes I do like 2-hour assessments. I
Yeah.
see kids,
Yeah.
so they're 2-hour assessments and I can't just get up and walk
Mhm.
around.
It's like,
Yeah. And I don't wear high
right side or left side?
It's just on this side.
I'm gonna bring the table up. So do you get stiff only on this side?
I don't get stiff, I
Okay.
just, if I sit
Just
for a
hurt?
long time, it just hurt, it starts aching.
Okay.
I don't get
And
stiff.
so sitting actually puts all the pressure right on the pelvis and
Yeah.
right on the, so that's where, so I'm just gonna look at this side, so just sort of see, and then relax. Ooh, a little tighter on this side. Can you hold it there? Don't let me move it. Good. And then can you hold it out there? Don't let me move it. Ooh. And then this one, hold it. Nice, and then relax that way, hold it. Good. Let me have you on your back, please. I'm just gonna do a quick sort of demo on what we already know is going on. So, I'm just gonna look at the one that's on. Ooh, no. Do you see how I can't really go there? If I bring it out, I can go further.
Okay.
So it's just your bones. It's just the way they are. Where do you feel this when I push?
Like you.
Back there. Okay. So it could be trying to stretch those. Okay. Ooh, that could use a little stretch. Okay. And then let's see what this one does. Any issues there? Where do you feel this? Also in the back?
Also.
Ah, now in there.
Yeah.
So different, right?
Yeah.
And this way?
Nothing.
Okay. You know there's a labrum problem in there. I'm not gonna put pressure on it and grind it because we don't need to figure that out. But there's really, so in my practice, I do an 1.5 hour evaluations where I take the time to find out what the cause is.
Okay.
Because otherwise, you're gonna be treating, oh yeah, stretches, strengthening, and not really be treating part of the cause. So different things would be sort of pulling, right, to create a little bit more space. That kind of movement also creates improvement in the way that fluid moves inside the joint capsule and helps things heal.
Okay.
So acute irritability, and you can also do different mobility here. So I'm gonna pull your hip this way. Because then, and so sometimes I'll use a belt because when I pull it out, then, and I can't do it without the belt, but if I pull it out, then I can move it out a little bit because I'm gonna have a little bit more space, and then I can rotate that out without paying for you. Can you roll on your belly, please? So, looking at, a little stiff, not a lot. And looking at the hip mobility, which is good. Here, here, and a little bit tighter there. All right. So part of the manual therapy would be soft tissue release, and this it just feels a little tight compared to the other side, right? Yeah. And so why is that still tight, right? Is it because there are a few things that are still weak, and these are trying to compensate, right? I don't know. I haven't tested you, but take your time and set up. But so yeah, so Roni, for you is going to be important. I'm going to bring this you're higher. There you go. Good. So a little bit of the tightness, and that could be indicative of, ooh, something is a little weak, and I could tell a little bit of weakness, but you also have that little bit of stiffness.
Yeah.
So that's how it would be addressed. And so some of the weakness then goes into some of the running mechanics. Do you want to
You wanna go on the treadmill?
take it on?
Sure.
Sure, you're here. This is all about you.
Okay, so we'll just get me on the treadmill and walking for a minute, just to get you in the flow. Yeah. And then there's this guy, we're just gonna build the speed. Yeah. Take it up to maybe like a 2.5, 3. Kinda get it going. And then once you go for like maybe like 1 or 2 minutes of walking, then you're gonna get up into a conversational pace. And I'm gonna take video from you from the side and from the back. I won't really be able to get it too much from the front, but I can see probably from here. But just getting into the walk through. Alright.
I do the rolling foam.
The foam roller? Mm-hmm.
Yeah.
And where do you do the foam roller, Roni?
What do you mean?
Where do you foam roll?
On my lower, like back.
On your lower
Not lower back, like the back of
thighs?
my leg.
Yeah.
Do you do it because it gets tight?
Yeah, we do.
So it's figuring out like, why does it get tight? Is it weak? Is it, because sometimes when things are weak and they overwork, they just get tight. And the shot feels great, and then you do it, and that's how you maintain it.
Alright, ready to start? We can start going up. Alright, so you're gonna get into just whatever feels conversational pace for you. And then I'm gonna let you run for probably about a minute, and then I'll start videotaping. So just does this feel like conversational?
Yeah.
Okay, cool. And no pain right now, right?
No.
Okay, great.
You're like, switch!
Huh?
Nah, you're just, okay, switch! So there's different things, I'll wait.
I'm not used to running in front of a mirror.
Right?
It makes me feel weird.
But it's actually good for form and training.
Yeah.
Okay. I want to do one more thing. Every time your right leg hits the ground, starting at, is this space still comfortable for you?
Yeah.
Okay. So you don't have to touch anything. So when this hits 45, you're gonna count your, every time your right leg hits the ground. I can start now. I'll tell you when to stop. And I'll have you hit it stop. What is your number?
45.
45, good. Okay. So, a couple of things, I'm gonna see what this says too. But a couple of things I did notice is, do you ever hold anything in that right arm when you're on the treadmill? No? Okay, so there's some protective thing going on with the right arm because it's pretty stagnant. It's not moving. So it's pretty static. This guy's moving.
Okay.
Cadence wise, I was having you check your cadence. Do you know what cadence is?
No.
Okay, so cadence is essentially how many steps you take per minute.
Oh, okay.
So ideally, the more steps you take per minute, it's a rate, and I'll explain it, the more efficient your stride is. So you want to be essentially between like 170 and 190. Like I'll give you an example of me. So like conversational pace for me, I range between like 176 and 180. When I start to dial it up a little bit, I can go upwards of like 185, and then when I'm like really dialing it up, I'm like in the 190s.
Oh, okay.
So it's variable based on speed. But the thing with cadence is that most of the time people have slower cadences because they're more like running like I'm bopping up and down and I'm like a pogo stick, or I'm overstriding and I'm trying to reach out in order to gain my speed. But you want to actually essentially shorten your stride up a little bit, fasten up your speed up your steps, and that's going to help with just transferring your energy from one foot to the next. Does that make a little bit of sense?
Yeah.
Okay, but you were good. You had 180.
Did you video the back?
Yeah, I did. So let's
And you've had back and SI joint stuff, not back,
Yeah.
but SI joint, so go ahead.
so let's just look through it. All right, so see what I'm seeing, how you're kind of rotating more through that side, and this
Oh,
one
okay.
is staying a little
Yeah.
bit more stationary and stiff.
And you're looking at her arms, but she's actually side
Oh,
bent.
she's leaning.
Yeah.
I didn't get, yeah.
Like the side
Yeah.
bent, like there's a lot
Yeah.
involved.
Exactly. So starting up here, and then we'll move down here, and then we'll like move down here. So let's go slow. So see how you're shifting over towards, watch,
The right.
yes. And then hippies wise, let's see what they're doing. So let's take you through. So let's get you through stance. So right about there, your stance phase. I don't see that much of a drop. I mean, it's a little bit going that way. And then right there, that doesn't really look like it's dropping too much on that side. But you maybe have better eyes with hips.
No, the one thing that I noticed is that she's not eccentrically unloading
No.
on the left side. And so not only do you
Yeah, she
do you side bend through your lumbar a little bit, you have this arm closer, this one's up a little, and I'm gonna exaggerate it, it doesn't look that bad.
No, it
A
doesn't.
little bit here, but then, and you
At
can
all.
hear it in your sound.
Yes.
You step, because it's not that you step harder, but because you're stepping differently on the left, so the left side isn't allowing you to come down and cushion it in the same way, so it's very stiff.
Oh.
And so some of that, I can say, hey, now, she's really stiff on that left side, that's creating much more stress right into the joint. So it's why aren't you cushioning it with your muscles as opposed to being so stiff into the joint?
Because you can hear the sound in the beginning. This is one reason why when I do it through this app, you can't hear your sound as much. You hear it in the beginning.
Yeah.
Oh, let me run. All right. So strike pattern wise, I think it looks like you strike. So your initial contact is with your heel, which is not necessarily always a bad thing. On the treadmill, you're landing underneath your center of gravity, so that's a good thing. It looks like you strike out more though. On the right side. So it looks like, I think on the right side she strikes out a little bit more than on the left.
What do you mean by striking out?
Overstriding.
Oh.
Just a marginal amount.
And that adds to the reason why her
Could also-
left side is a little bit, she's not extending through her
Yeah.
left side as much. So that adds to that. So she might not be over striking on the right, but under
Yeah.
on the left. And some of that is, I can see just a little bit less hip extension
Oh,
on the
she did,
left,
definitely, yeah,
than the right.
yes.
So that might be the reason why we're seeing the,
Yeah, sorry, I'm just watching.
no, that's fine, but that's what I'm trying, that's what I think.
Yeah.
And that might be just maybe her glutes aren't, maybe your glute muscles, your glute max isn't firing well, maybe it's just restricted in movement with flexibility, we didn't really look at that.
Yeah,
Maybe it just doesn't have the right motor mechanics, so you might be super flexible and your glutes might be super strong, but you haven't, it's like your body's still functioning as if it was injured and it just never learned to, oh, now you're stronger and now you have to take the movement. So do some of these running drills like glute striders or different drills that sort of break down the running movement to teach your body how to run again, because now you're stronger and now you have proper mechanics.
trying to see. It was almost like, it's not that. Your first stride almost looked like you were a little bit more, landing on your forefoot at first, but it's not.
Isn't this fun, having like big part?
No, it's good.
Cause it's, the way that I do form retraining anyway, it's about fine tuning you, it's not even about wholesale changing
Yeah.
you, cause the analogy I usually give, did you ever watch Friends?
Yeah.
Okay.
All the time.
Remember the episode of Phoebe and she's like running next to Rachel and she's like, come on Rachel, let's run! So if you look like Phoebe from Friends, then there's like wholesale changes obviously you have to do with your form,
Yeah.
but most of the time it's just fine tuning. Is that totally gonna be on video? That's amazing.
Yes.
Woo! Alright, so posturally, let's just check that out. I wish I'm gonna say most likely I didn't check you from the front, so just based on that, it looks like she might be crossing her midline with her arms,
Yeah,
but I didn't
and
say
you can see it from the back a little bit,
Yeah.
very little. And I think that has to do, like she said,
Yeah.
a little bit of scapular elevation. This one's really close, and so that
Yeah,
kind of adds to
so you don't wanna be here, but there might be some structural things that are going on that, obviously I wouldn't be able to address, but just kind of cueing you to be a little bit looser
Oh, okay.
from your shoulder joint and thinking about elbows back as opposed to, but because of the rotation, at least I was seeing, it could also be a reason why you're crossing your midline. So,
And some of that could be the way that you sit at work.
Good thing.
true.
Most often, dominant side is a little bit lower,
Mhm.